Good morning. My name is Maya Hendel, and I'm the Education Manager with the Minneapolis Heart Institute Foundation. We're very excited to have you all here today. So I'm just going to do a quick welcome before we get started. Welcome to all of you, and a big thank you to our exhibitors and sponsors who are here today. Hopefully you had a chance to chat with all of them who helped make this program possible. Here's our schedule for today. We've got some great speakers with the Allina Health Minneapolis Heart Institute who will be joining us. And then we're fortunate to also be joined by Betty Brand, who's a patient who will share her story. And at the end, we'll have some time for questions and answers. So if you've got some questions that come up, write them down and we'll have some question time at the end. A little bit about the Minneapolis Heart Institute Foundation. We've been around for over 40 years with the mission of leading life-saving cardiovascular research and education to improve care for patients around the world. One of the ways that we do that is through our strong partnership with the Allina Health Minneapolis Heart Institute. And so we work together doing research and education to improve clinical practice and patient care. Here's just another few more examples of the work that we do and how we get our research out there through patient enrollment and research. We've got over 200 active studies at any time, 500 plus publications, presentations, getting the word out there about our research. And then, of course, having visits with patients to help improve their options through research. We are a 501c3, and so philanthropy is an important part of what funds us. And so thank you to those of you who have donated before or who perhaps will donate in the future. We're very grateful for that support. And one of the ways that that support makes our work possible is through the Joseph F. Novogratz Family Heart Rhythm Science Center, which is what's bringing this program together today, leading the way in advancing heart rhythm research. And so with that, we'll get started with our program. Our first speaker is Dr. John Zacabe, who is a cardiac electrophysiologist at Allina Health Minneapolis Heart Institute. He completed his medical training at the Medical College of Virginia and the Cleveland Clinic. He treats a variety of heart rhythm disorders, including invasive and non-invasive management of atrial fibrillation. And outside of his clinical work, Dr. Zacabe enjoys baseball, photography, and sailing. So welcome.
Okay, I'll try. Good morning. It's a pleasure to be here with you all, and it is so nice not to be at work. So it's great to be here in a foundation event and sharing this time with you all to talk about arrhythmias and what we can do about them. I feel like I talk about that all day, every day at work, and in the office I have a conversation with patients about managing atrial fibrillation, about what's the problem with the heart and what we can do about it. And I've been doing that for 20 years. It's amazing how we can offer metaphors. We can use examples of things that people innately understand and relate them to complex problems like heart rhythm problems and give people insight into their heart rhythm problem by relating to something they already understand. So I've never done this before where I'm going to try to offer those types of metaphorical examples to a large group that's not really talking back to me, but we'll try it and see how it goes, okay? You can talk back if you want to, actually. Maybe that'll help us. So I said this talk should be called How to Think About Atrial Fibrillation Like a Normal Person. So not like a physician, not like an electrophysiologist, but like someone who needs to understand what's happening within their own heart or within their loved one's heart, and how it works and what we can do about it. So we need a plan. For the morning, actually. This is a bigger plan than what I'm going to do, so I'm going to break it down. We're going to discuss a little bit about how the heart works, because you need to know how it works so we can talk about the derangement of atrial fibrillation. And then we'll talk about atrial fibrillation. We'll talk about the risks associated with atrial fibrillation, and I think Dr. Sengupta is actually going to cover some of the things we can do about that. Am I right? Yeah, good. Okay, he agrees. And we're going to talk about what we can do about atrial fibrillation. And Dr. Olson is actually going to talk to you about technologies available to us now to help mitigate this problem. But it's a massive problem. And it's interesting. There's a statistic I learned the other day. I'm sort of like the Cliff Clavin of electrophysiology, but I'll tell you a fun fact. So in 2010, we thought there were 2.2 million people in this country with atrial fibrillation. And the prediction was by 2020, we'd have 4.5 million people with atrial fibrillation. And that's an incredibly daunting explosion of this rhythm problem. But the estimate that was published last week, according to census data and a variety of other statistical methods, was that there are 10.5 million people in this country with atrial fibrillation. So we have a massive tsunami of this particular problem to manage. Now, another statistic I learned, and I've been showing it around the office this week, there are, for scale, 1,200 young people in this country for every pediatrician. There are 7,700 adults for every anesthesiologist in this country. About 14,000 adults for every adult cardiologist in this country. For every electrophysiologist, there are 124,077 adults in this country. So we don't have the resources we need to manage this problem effectively. And I don't think we'll ever train enough people to manage it. But at least we can help understand it this morning, and we'll solve that problem, okay, at least for you all. So, but be optimistic. And I'll tell you this, and I tell patients this all the time, there's never been a better time to have atrial fibrillation than right now, because at least the things we have to offer are helpful and effective. Okay, so this is a slide about the electrical activation of the heart. The heart is a 4-chambered pump, and it is under electrical control, so a mechanical flow pump under electrical control. And it's really elegant. I don't know if I have a pointer. Maybe this doesn't really point. It's really an elegant and effective pump. In this picture on the left, you can see I have an animation of how the heart it beats when it's normal. You see the upper chambers squeezing under the signal from the sinus node. That's the heart's own pacemaker up there in the top left. The atrium squeezes and pushes blood into the ventricles. The ventricles are stiff and muscular. They don't fill very well on their own. Like you could imagine, if you just dip a balloon in water, it doesn't fill very well. But if you force water into the balloon, it's gonna expand because it's a little bit elastic. The ventricles are the same way. So the two lower chambers are ventricles, and they're thick and muscular, and they're responsible for generating the high pressure that becomes your pulsation when you feel your pulse. But you got to force some blood in there for it to pump effectively. In the center, you can see that's called a telemetry tracing, or an EKG, and you can see that it's just a continuous repetitive pattern, and that's the electrical signature of the activation of those chambers. On the right over there, you can see a schematic of the electrical system of the heart, which I'm not going to explain. But ask yourself this question: what is the result? What is the effect of ordered electrical activation of this mechanical pump? That's a great question. I'm glad you asked that. Well, the answer is efficiency. The heart is incredibly efficient at doing its job. The average person in this room is pumping, let's say, 5 liters of blood per minute at rest to keep their body alive and happy. And they can do that with 60 heartbeats per minute. And I did some math here. If you do 60 beats and 6 liters, you're pumping 100 cc's of blood per minute. Actually, at rest, the heart probably doesn't really want to pump that much per minute. What are the limits? What are the extremes? Has anyone here heard of Michael Phelps? Okay, the only reason you have ever heard of Michael Phelps is that he doesn't have atrial fibrillation. At peak exertion, when he's winning a gold medal, he's going 190 beats a minute, and his heart is pumping 32 liters of blood per minute. Another famous athlete you may have heard of, Lance Armstrong. He was actually demonstrated to pump 40 liters per minute at peak exertion, and this is over 200 beats a minute. So you can see there's a tremendous and dynamic range of contractility, where the heart can squeeze harder and it can squeeze faster. And that synchrony between upper and lower chambers is what gives you the ability to have that dynamic range. Okay, so we need to talk about atrial fibrillation and the derangement of that and why it has such an effect on cardiac function. So let's just take a poll. Raise your hand if you've ever been in a bar fight. You want it? Okay. Seriously, there's more than one person that's been in a bar fight here. Okay, you crashed my presentation. Let's talk about how this problem starts. Atrial fibrillation is a triggered event within the heart. The heart's ticking along normally, okay? Let's not use a picture. I find when you put slides up, people just stare at the screen. So look over here. Let's use your mind's eye to put a picture of what's happening that you can understand. And then I'm going to show you, I promise to show you some pictures of this electrical activity in the heart. Has anyone ever seen a Western movie where they're showing you all the goings on in the saloon? And the people are playing cards and the guy's playing the piano and they're serving drinks and it's the normal ebb and flow. There's some ladies with extremes amount of fabric that they're wearing, you know, these huge dresses, and everything's normal. And then one guy stands up at the card table and punches one other guy. And immediately, everyone in the room punches everyone else, right? That is how atrial fibrillation starts, okay? So it's a triggered event, okay? The heart, I'm gonna relate that to the heart here just briefly. The heart is made out of cardiac muscle. It's a specific type of muscle cell. And the pulmonary veins, these are the veins that bring blood from the lungs and drain that blood into the left atrium of the heart. Those pulmonary veins are made out of smooth muscle, just like the gut, okay? And these two muscle cell types are not particularly similar. Smooth muscle is wispy and thin, and cardiac muscle is pretty durable and it fires all the time. So they're different. And the border zone between the pulmonary veins and the heart is characterized by these muscle sleeves, okay? There's a sleeve of smooth muscle tissue extending into sleeves of cardiac muscle, and there's this border zone that is heterogeneous, you know, that's difficult for electrical signals to cross, okay? So people who have atrial fibrillation have a trigger in the pulmonary vein, some abnormal spot somewhere in the vein that likes to fire off on its own occasionally, just like that guy that throws the first punch in the bar fight. And let's say that trigger just fires off 10 beats at 300 beats a minute, and then it stops, it's done. As those signals, those wave fronts, like where the pebble hits the puddle, Wave goes out in all directions. When that signal propagates forward through that smooth muscle vein wall, as it crosses that border zone, here's another image. It's like throwing a snowball through chicken wire. You get dispersion of that snowball, right? As a wave comes through that border zone, you get dispersion of that electrical signal. And as you disperse the signal into the atrium, it fibrillates. It goes completely haywire. Once that happens, you don't really need the trigger anymore. Once the bar fight starts, it doesn't really matter who started it. And that guy, you don't even need that guy in the room anymore. The bar fight's going to keep going. And it keeps going until it peters out. That's how bar fights go. That's how AFib goes, at least initially. Now, sometimes there's another phenomenon called atrial flutter. Flutter is an incredibly incessant, repetitive circuit that gets set up in the heart and it never goes away. So imagine all the drunks in the bar. They're weary of that fight, and when they finally quit, they go into singing 99 bottles of beer on the wall. And now they're never going to stop. They're just singing, right? And that's kind of how atrial flutter comes after atrial fibrillation. And that's common, those two go together. So that's sort of how it works in a nutshell. You may have also heard of cardioversion. Cardioversion fits into this little metaphor also. As the bar fight rages and the sheriff comes in and stands there observing all of this for a little bit, eventually, you can raise your voice if you want to, but you're not going to get everyone's attention. So the sheriff shoots the gun off up in the air, and suddenly everybody freezes. Everybody sits back down, and everything goes back to normal. And a cardioversion is like that. It's like an electrical shock that resets all the heart muscle at the same moment. So it's going crazy, and it's haywire, and then it suddenly gets reset, and it goes back to normal. So cardioversion is like the sheriff shooting off the gun. It does not prevent tomorrow night's bar fight. It just resets everything and it all goes back to normal. No one wants to get in trouble, right? The thing that prevents tomorrow's bar fight is excluding the initiator. Taking the guy out who's going to start tomorrow's fight and put him in jail, right? Or wherever. Send him out of town. If no one starts the bar fight, there isn't a bar fight. And that is how we mitigate atrial fibrillation using ablation and other interventions. We're preventing the initiators from disturbing the atrial rhythm by excluding all that substrate that I was telling you about, that border zone. If we can exclude that border zone, then there is no bar fight. It's like a juice bar. You ever seen a bar fight in a juice bar? I bet, it's a different group of people, but I bet you couldn't start a bar fight in a juice bar. Nobody wants to fight. Everyone's happy. They got their glass of wheat juice or whatever. So let me walk you right back through. We're in the bar. We're in the left atrium, the left atrial bar. We're in the saloon and everything's going along fine. I don't have a pointer, but if I'm mapping in the left atrium with a catheter in normal rhythm, what I'll see is I press my catheter against the muscle is an electrical signature when the heart squeezes, when that part of the chamber squeezes. And then it's going to be quiet until the next signal to beat. And then it'll be quiet until the next signal to beat. That's called sinus rhythm. That's normal. And then somebody decides to throw their first punch. Here we're in the pulmonary vein. Normal signal. Normal signal. Normal signal. And then bang, right here. Something fires off really fast and gets the whole thing disorganized. And now we're in fib. We're going fast and completely disorganized. So if I put the two side by side, this is normal rhythm. There's the heart beating nice and normally. And that's atrial fibrillation over there. It's complete electrical disarray. So the upper chambers are shaking, quivering is 600 beats a minute or more. There's no pump function. They're just shaking. And the ventricles, the main pumping chambers, respond as fast as they can. Here's atrial flutter. You can see it's a large circuit that's chasing its tail around the tricuspid valve. Okay, this is 99 bottles of beer on the wall. This is never going to go away. But if you shock a person and we sedate them before we shock them. My kids, when they were little, kids, I got to go to work. Are you going to shock them or burn them today, Dad? Fast forward to my son's 18th year. He's 18 years old. He spends a week with us at Abbott ablating AFib, and he comes home and he's like, "Mom, do you have any idea what Dad is doing at work all day?" So here's a map of the pulmonary veins on the back of the left atrium. So if I show you this chamber, and you see those 4 holes up there in the back of that chamber in the high right, that's actually the left atrium. Those are the 4 veins draining blood from the lungs into the left atrium. And if we go forward here, now if you visualize that we're looking at that chamber from behind the chamber where the spine would be. In this voltage map on the left there, purple is normal voltage, that's normal muscle, and red is no voltage. So you can see as you get far enough out into the lungs, there's no voltage. But this border zone right here and here, that's that smooth muscle, cardiac muscle interface. And when we put a line of burns around the opening of the veins, now you can see there's no voltage here. So we have a line of burns that's going to result in a line of scar. We've excluded that electrical activity. So scar doesn't conduct electrical signals. So if you have a spot that fires off right here, it's bounded and it can't disturb the atrium. And now when you pace the atrium, you can touch the back wall of the atrium. You can pace it at 300 beats a minute. It won't fibrillate anymore because all that substrate that disorganizes that tissue is quiet and gone. Here's a great moment. When you're ablating, you got in yellow our ablation catheters delivering energy in a spot, and we're going to terminate AFib. You can see how disorganized it is, and then it terminates, and you go back to serenity, right? And here's a person whose electrical substrate has been modified so the atrium is in steady, normal rhythm. So the heart is beating normally. And if you can see at the bottom here, I've got a catheter out here in the person's pulmonary vein. This is an old catheter, we're going to use the same one. And our burns are maybe around the opening here. So that when you're recording the rhythm in the atrium, it's normal. There's a beat, and then it's quiet, and then there's a beat, and it's quiet. Just like when you're listening to the radio in the car, and you got music. If you tune that radio over 1/10 of 1 megahertz to a different frequency, there's static, right? Like this, electrical noise. Now you tune back to the music. That electrical noise is still there, but it's just not bothering you anymore, right? It's not disturbing you. This electrical noise can be here. Maybe it burns calories. That would be great, right? But the heart is undisturbed and it's normal. So the big picture, let me just wrap up here. I've given you some metaphors. I threw a snowball through chicken wire, and we've been to a bar fight, and we ended up in a juice bar somehow, and listen to the radio and the static and all of those things. They're all just ways of thinking about these complex problems in ways that you already know and understand. But the big picture is atrial fibrillation is a rapid and disorganized rhythm of the upper chambers of the heart. It can have a range of symptoms. It can be asymptomatic. It can have oppressive symptoms. It carries some risk for stroke, and it carries some risk for congestive heart failure. And we can manage those risks with medicines that help us slow the heart down and medicines that can help us stay in normal rhythm. We can shock the heart under sedation and keep people and restore normal rhythm. It doesn't change what's coming tomorrow. We didn't change the substrate, just like when you get what they used to call the blue screen of death on a computer when it turns blue, and all you do is press reset, start over. It doesn't mean it won't crash again. It just means you get to keep going for some period of time until it does. We can give medicines that help suppress atrial fibrillation. And we can ablate, and you're going to hear a little bit about that a little bit later, but at least to introduce it, we're just going to modify the substrate so that the electrical activity that's abnormal no longer disturbs the heart. So 10, 15 years ago, I sat at a round table like one of these with a bunch of heart rhythm doctors who said, you know, you really have to be an optimist to treat this problem, because we had these procedures that were prolonged and difficult for everyone, the doctor and the patient and everybody else, and they didn't work that well. And now our procedures are incredibly effective and much easier to tolerate and relatively brief anymore. So there's every reason to be optimistic about the management of atrial fibrillation. So with that, let me conclude. I'd like to introduce our next speaker, who is my colleague, Matt Olson. And Matt is a bioelectrical engineer who is also an electrophysiologist. I was hoping I would pronounce that correctly. So he is going to talk to you about technology in therapeutics for atrial fibrillation. So let me introduce Matt. Dr. Olson.
Thanks a lot, John. We just listened to the Garrison Keillor of electrophysiology. So I get the unfortunate honor of following that. I will use a lot of pictures. You don't have to close your eyes, and I'm not that eloquent. So my job really is to try to continue to recover from my engineering training and figure out how to teach some complex and use technology and expose you guys to what it is that we're using in the electrophysiology lab. Brief story is I remember talking to a senior cardiologist who has been retired for years, and the field of electrophysiology was really in its nascency. It was started in the 80s, early 80s, and he retired in the 90s, and he called it the Star Wars of cardiology. And John and I were joking, like we always draw things back to Star Wars, but you know, this is kind of the futuristic field in cardiology, and it has allowed us to treat things that, as John had alluded to, are very complicated and thought we couldn't potentially treat. So today, bear with me, we're going to start at the high level, and I'm going to bring you down a little bit deeper into the weeds and bring you back up. And the whole idea is for you not to even tell me about the frequency of radio frequency ablation, but to understand some of the fundamental concepts we use while treating atrial fibrillation. So we're going to go through the diagnostics, figuring out where the rhythm is, how it's working, what we use for the diagnostic purposes in the electrophysiology laboratory, and then we're going to touch on the therapeutics or the ablation components, all right? So first, diagnostics. One of the coolest things as engineers figuring out how we can show you these beautiful pictures of the heart. So I grew up in the early era of video games, and my parents are like, video games are gonna rot your mind. We don't tell you this, but we play video games when we're in the lab. We literally do 99% of our work using what we call three-dimensional mapping. It is essentially a computer-generated understanding and anatomy of your heart in real time. So almost all of the work we do is through computer generation and on the screen, which is a dramatic change from 10 to 15 years ago when we used radiation and fluoroscopy. So you can do these without using radiation now, using just the computer technology. And to do that, it's using magnets, special magnets that sit underneath the bed, magnets in the catheters I'm going to show you, and some patches that create some electrical noise, and how that noise is disturbed helps position the catheter. So with the magnets and the electrical signals, you can position catheters and generate these maps to high precision, far greater than anything we could have imagined. In the last 10 years, we've essentially developed high zoom lenses. Just think of your old iPhone, right? The original iPhone 7, we were amazed you could take that picture. Now you get the new iPhone, you can zoom in 10 times and take a better picture from across the river valley here in Minnesota and get a better picture than your friend's face 10 years ago. The same kind of concepts we're able to do here using these really interesting mapping systems. So when we show you maps, they're generated through this process of acquisition. So I'm not going to show company names here, but there's different types of catheters. Think of these as our zoomed in lenses, and we paintbrush the heart, and these small electrodes or sensors. The smaller the sensor, the more accurate it is, the more zoomed in the lens is. Okay, the original mapping catheters had big sensors, all right, not very sensitive. Now they're tiny and small, and there's 20, 30, 40 of them on a single catheter. So if you think about how hard it is to shake something that's small or very big, it's going to be a lot easier. Lighter and smaller is more sensitive. Think of it as that zoom lens. So we're able to create these highly detailed maps of your electrical activation of the heart using these catheters in three-dimensional space. So that's the mapping catheter. That's how we create the picture. That's how we figure out the structure and electrical health of the heart. So as John was saying, these catheters are used to figure out where is that border zone. I like to use the term electrical arthritis, just like knee arthritis. That joint is dissimilar, it gets inflamed. How arthritic is the joint? How deep into the atrium does that joint go? Where are the smaller areas of arthritis or triggers that we couldn't see before that we can now see? That is really the massive advancement in mapping and diagnostics. For those of you who have had an ablation, this is your least favorite part. We're going to take 12 cold stickers and a cold lab and stick them on you, right? This is the part where we put all those stickers on to create that map. That's why we do it. We don't do it because we like to torture you, but this is the real purpose of it. So this is a case I did this week. I told the patient I was going to present his pictures. He had a very photogenic atrium, and so he was happy about that. But just as you had seen the illustration before, this is using the right atrium is the one on the left side of the heart. You're looking at the heart. The left atrium where AFib resides is on the left side. You can see nicely the normal pacemaker of the start is on top right of the heart, the sinus node, and it washes over to the left side of the heart, okay? This is before we did the ablation. This is normal electricity. So we're able to generate this entire map, which is showing the exact location of your atrial tissue, the timing, activation, and electrical health of the tissue for every patient, okay? We don't necessarily create this activation map, but we do the same process for all ablations. And I just like this because it illustrates quite nicely what your heart electricity looks like for a single individual, all right? Another important technology we use is intracardiac echo, or we call it ICE imaging, all right? ICE imaging is like the ultrasound for babies, right? Everyone thinks about that. Same thing, whereas now you have live 3D ICE imaging or live 3D images of babies. When I first started, we had just developed a single image over here on the left where you create, essentially think of like a fan, one of the old fans that you can fan with. These ultrasound catheters create a fan and you rotate them through, and that fanned image shows you a picture, a single slice of the heart anatomy. And it took a long time for those of us who had to recreate the heart three-dimensionally in our mind using a single slice at a single time. It actually took years to really get good at that process. Well, the newest technology using artificial intelligence is able to, I'm jealous of the new trainees because all they have to do is put the catheter up and kind of slowly, wash it through the heart, and the software creates an entire left atrium through a single pass, which it creates it in that same mapping system. So we went from, back before ultrasound, you wouldn't even see the heart at all live, to getting a single fan or a single image to now being able to reconstruct through AI the entire heart. And this is the image of the patient that I did on Thursday. So it's a couple minutes to create this, and it is really incredible how far the imaging, processing, and software has come. So that's the imaging part. So we use ICE imaging or echo imaging for safety and structure and real-time understanding, the electrical anatomic map or the electrical mapping to understand health of the atrium, where we're going to do our therapeutics. So we have structure and function combined together. Every case we do this. Then also in the future, the video wasn't working, but we create three-dimensional real-time images using the ultrasound. That's not really a topic today, but that is something we're moving towards. So that's going to be, it's here. It's not quite as good as we want it to be, but that's really the next step, is three-dimensional real-time imaging from inside the heart. All right, now why we're here is therapeutics. Now, I'm a recovering engineer who spent 10 years working on ablation biophysics with my mentor. And so this is hard for me because I have to avoid the technical jargon. You can throw something at me, John, if you need me to come up for air, okay? So radio frequency. What is radio frequency? This is a way to generate heat. The first two types of energy, what we call cryoablation, freezing, radio frequency heat, it's thermal injury. The analogy is you put your hand on a hot pan, it burns it, freezes it, or in Minnesota, you don't wear a glove and you grab onto a cold pole and you hold it there for a while. Okay, those are the two types of injuries that happen. So radio frequency, if you know this is an old shot from your high school class, right? And you can see that microwave energy, everyone's got a microwave, you put water in a microwave, meat in the microwave and turn it on, it heats it up. Radio frequency ablation is just below that frequency cutoff. They tried microwaves that we've all put water in a microwave. It doesn't work so well. The body's mostly microwave, mostly water. So we have to go just below that spectrum for good heat generation. There's a complex electrical circuit. I just put it up there for you guys to see that there's a lot that goes into how that circuit actually works, okay? But essentially, it's a ground pad and a catheter, and electricity is put through there at a high frequency, and it generates heat at the tip of the catheter. Okay, radio frequency ablation, thermal injury. All right, so what's really cool is how far we've come. We've come to a point so much so that this catheter can be positioned in space, can show force. So there's two different mechanisms. This one I'm showing you is called the Q-dot catheter. It has a little spring, and as that spring moves in space, there's three magnetized coils, and those coils shift. Those small movements in how they change are then referenced back to force. So if you think about that, we're talking about a couple millimeter, 4 millimeter diameter catheter flexing tiny amounts, and those small movements can be factored in and determined force. Force is determinant of how the lesion works. So that's one area. And then even on top of that catheter, you have these little dots here. Those are tiny electrodes. Those are like super zoomed in lenses. These are the ability for us to zoom all the way in, that macro lens, if you will, where you can put it on something, take a picture, and zoom way in really close. So not only can we measure force, we can have these super zoomed in pictures and deliver energy. And this is where the zenith of radio frequency technology. It's been around for 25 years. What did Scheinman do in the mid-90s, I think, was the first US ablation in humans using the same fundamental technology, okay? But it's moved so far along. The other type here is another really interesting way to measure force is it uses high frequency light. And as that light is bent, it actually is correlated back to force. And on the end of this catheter is this highly machined tip that allows it to move and grab onto tissue in a very soft, gentle way. But it's kind of like Velcro. That tip grabs onto the tissue and holds it really stable. So now we've moved from a big catheter with blind to high zoomed in, high detailed specificity, force, and a really a potent way to generate energy, thermal injury to the heart tissue. The nice thing about RF energy is it's customizable. It allows us to figure out where, how, when we deliver the energy. And this picture I showed you here is from that same case where Dr. Zakeva talked about those veins being the first punch of the bar fight. And here you can see the electricity is coming into the heart. after we've gone through and ablated around the veins, there's no electrical activity going out into that feathered region, okay? And this is a RF ablation. The next type of is the freezing, cryotherapy, all right? The cryotherapy is a balloon. It's pushed up into that vein, and then it's frozen. You have to freeze a couple times. We found that freeze, thaw actually creates better injury and cell destruction than one single freeze. So you'll hear a cryo balloon, and that's what the cryo balloon or the freezing type is, okay? And just to quickly show you, it sounds pretty straightforward, but if you think about through a long tube through the groin, you're delivering freezing cold gas into a compliant balloon that is steerable, sends back electrical signatures, and is compressible and collapsible in time. Try to put cold water through a straw, any type of thing like that. It is very difficult. So the science and engineering that allows us to freeze, thaw, collapse, and control a catheter from the groin up in the heart is actually quite complex. So it's just good to think about that. Having designed devices, freezing and thawing is really difficult on any type of machine, let alone a therapeutic. All right, last but not least, pulse field ablation. This is the new kid on the block. It is probably in our field, the most talked about in quite some time. Why haven't we've known about it for a long time, but technically, why is it just coming to be? It requires high energy. So a plugged-in outlet is 120 volts at 15 amps and 120 hertz. The pulse field ablation needs a 500 volt microsecond pulse for this to work. And it has to be a perfect square wave. So not to get too far into, but the way to get capacitors to hold that type of energy, to discharge it, and to do it repetitively, effectively, was very difficult. Once that the electrical breakthrough that occurred, where we were able to do that effectively, allowed us to get to pulse field ablation. So we've known about it for a long time, but it's not till recently that we've had the capacitor technology to create that discharge waveform. Well, how does it work? Essentially, every cell has a membrane. It's an electrical barrier. It's made up of two different phospholipid layers, and you discharge this energy in a really fast, really quick way, and you shake the cell. And when that shake occurs, the cell opens up. Essentially, it's kind of like warp speed, back to my Star Wars theme, where Star Trek, where the hole opens up. The same thing happens here. The cell membranes open, and the cell is electrical, right? It's beating, it's conducting electricity. You open that membrane up, and essentially the machinery on the inside of the cell fries. It's like an electrical bolt. Your house gets struck by electricity, but it's a single cell. The great thing about this is there is no thermal injury. It is not heat. So any thermal injury causes some potential collateral injury. This does not have thermal injury. It is an electrical shock that allows for the cells to be injured. It's more tissue selective. And for this case here, I showed the esophagus is on the left side, right here. In a perfect world, I would have gone further out, but the esophagus was heating. And I had to sneak a little bit off the esophagus because of that thermal injury. If I had pulse field, I would have moved that line out, because we have to balance the safety and efficacy of every procedure, okay? So there are multiple catheters. This is in the infancy. This is a couple years out. And there's going to be a lot of change over the next 3 years until we really figure it out. It's good right now. It's going to be much better after we get the understanding and experience. And both Dr. Zakeb and I were, the industry wants, someone to close their eyes, press a button, and it to be done. We like to be very specific and very calculated. And I think once we get the perfect tool to have that perfect, miniature scalpel and do exactly what we want, that's when pulse field ablation will really be, I think, the number one technique and therapy. So with that, I will conclude that there's a lot of technology. It's continually changing, and every different source technology has its benefits, and we choose one or the other for patients based upon multiple factors. We won't go into all that. I'd lose you even more than I already have. But anyway, that's it from the technology side. My main job was really to make Dr. Zacabe and Dr. Sengupta look good. So hopefully I've succeeded. With that, Dr. Sengupta is going to speak. He is the director of the Heart Rhythm Center, is a consummate scientist, a lovely individual, smart, hardworking, and really a joy to share a lot of ideas with. And I have never heard him say no.
Thanks for that. Thank you. Well, thanks, Matt. And now everybody knows why I like coming to work every day. I get to work with Dr. Olson and Dr. Zacabe. It's truly a joy. And, I think that's also a great thing about our practice is that we really do work as a team and bouncing ideas off of each other. And this Heart Rhythm Science Center that we have has been a great addition because in addition to working with the latest technology as they've gone through for you so beautifully, we get to see how we use it best for the benefit of the patients, because the patients really do come first. And I do want to thank our sponsors here today, because those are the industry here in Minnesota, which we actually, Dr. Hauser presented on it last year, is really the basis for a lot of this technology. And we get to work with them too in terms of developing that and using that. And so it's really been a great opportunity. It's really a joy to work at Minneapolis Heart Institute for those reasons. So with that, I'm going to talk a little bit, shift gears a little bit, because I think Dr. Zacabe and Dr. Olson were beautifully explained kind of the concepts behind why AFib occurs. And I'm going to talk about something serious related to AFib. So the star of my presentation is a part of the heart called the left atrial appendage. And so far you've been living in the left atrium. And if we use Dr. Zacabe's analogy, the left atrium is the bar where the fight is happening, and the left atrial appendage is probably the broom closet off to the side of the bar. But the door to the broom closet is still open. So we're going to talk about what that is. But Dr. Baba was our research scholar who helps us with the research and analysis. He helped me put these slides together. And he and I were talking yesterday. We were just very impressed about the stroke rates in the United States and how many people have had a stroke. And that's on the graph on the left side is the prevalence of stroke in the United States. So it's more common as we get older. And if you look above the age of 80, and you look at men and women, looking at 12% or 13% of the population that have had a stroke, and more commonly in women. And stroke, as you know, is one of the major, arguably potentially the most serious complication of having atrial fibrillation. And if you looked at all people who had strokes, about 20%, almost 20% of those strokes that happen to be related to a blood clot going to the brain or stopping blood flow in the brain happen to be related to atrial fibrillation. So it's a major part of our treatment of atrial fibrillation is understanding what that stroke risk is for a particular individual and how to reduce that stroke risk. So AFib, as you know, is a major cause of stroke. 800,000 people have strokes in the United States every year, and upwards of more than 75,000, and it's much more than that, I believe, are related to AFib. And it has to do a little bit with this highway that exists between the heart and the brain, which is the arteries that take blood from the heart to the brain. Because when we're talking about an ischemic stroke, it's about a clot that goes to the brain and prevents blood flow to part tissue in the brain, and that's when you have the symptoms of a stroke. So that blood clot could come from other parts of the body and make its way through the heart on the way to the brain. It could come from the heart, or it could come from somewhere on the highway, the artery that connects the heart to the brain, the carotid artery, and the arteries inside the brain itself. If the clot comes from the heart, the most common location is this part of the heart that I named, that I referred to earlier, called the left atrial appendage. And the appendage is, like I said, it's like that broom closet. It's kind of a little outpouching of the left atrium that sits off to the side. And this is an anatomical specimen. You can kind of see it here off of the left atrium. The left atrium is kind of on the back side of the heart, the upper chamber, and the left atrium appendage comes off to the side of the heart, or in front a little bit. And it's kind of the most primitive part of the atrium that formed in utero during the heart's development, embryogenesis. And it still remains as part of the heart as in our fully formed heart, and it still has tissue around it that contracts and pushes blood. But what happens when you go into that chaotic atrial fibrillation, that bar fight, is that the blood flow in the appendage tends to be more static. There's stasis, the function of that appendage is not as pronounced, and so the fact that and other factors account for why blood in the appendage tends to form those clots. And so the clots form there, not all of them, but 90% of them. That's a very important point, more than 90%. And then that typically is what exits from there and travels through the bloodstream to the highway and to the brain that can cause a stroke. And this is not new information. Actually, I was surprised to find that scientists Welch in the early 1900s recognized that many of those blood clots come from the left atrial appendage. And Dr. Olson referred to how we image the heart. It's such an important part of our daily practice. So in order to understand someone's appendage, we have tremendous tools that we can see their appendage through with CT scan imaging, MRI imaging, and ultrasound or echocardiography imaging. And on the other side of the screen are some of those images. Here's an example of a CT scan where we can look at what the left atrial appendage looks like in this individual, and we can kind of cut the heart in different ways and reconstruct it and look at that appendage. And it turns out that everybody's appendage is a little bit different. So my appendage is a little bit different from Dr. Zakeib's, who's different from Dr. Olson's. They have different shapes and sizes, and we'll talk about that in a second here too. But before we get there, I just want to talk a little bit more about stroke and AFib, because we talked about how this is such an important link and how we need to figure out how to reduce your risk of having a stroke. And once we discuss that, then we can talk about, well, what are the treatment options that we use to reduce that risk of stroke? And so I apologize for the busy side, but I'll try to kind of walk you through this. What's counterintuitive about this is that you may get a certain treatment for your AFib, whether it's a medication or whether it's an ablation procedure, but independent of what that treatment is, we still assess your stroke risk. So just having the ablation doesn't necessarily always reduce your stroke risk. It depends on other factors that you have that are tailored to your medical history. And this is what we've kind of created or come about called a scoring system, and it's now become what's called the CHADS-2 VASC score. So depending on your score on this particular way to calculate, that tells us what your stroke risk is per year with your history of AFib. So the CHADS-2 VASC score, and you can kind of do it on yourself, just walking through it, has certain conditions. So if you have a history of heart failure, if you have a history of high blood pressure, if you have a history of where your age is greater than 65, you get 1 point. If it's above 75, you get 2 points. If you've had diabetes, if you've had a stroke, you actually get 2 points. And if you're a female, you get 1 point, because women, we saw, have a little higher risk of stroke than men. And you're right, many of these factors we can't really control, but it helps us quantitate your stroke risk. So if you're a male and you have more than 2 points on this score, any two of those conditions are 2 points, or if you had a stroke, which accounts for 2 points by itself, you're already at the threshold where we would consider a blood thinner for you for atrial fibrillation. If you're female, 3 or more points on this scale, and we're usually recommending a blood thinner. And what that correlates with is a 2% per year risk, at least, of having a stroke related to AFib. So even if you have AFib and you're doing great and you had an ablation with Dr. Olson and you're not having AFib, but you have high blood pressure and diabetes, we're going to recommend a blood thinner for you. And even if you have AFib all the time and you feel fine, same thing. CHA2DS2-VASc, if you're male and your score is 2 or more, or if you're female and your score is 3 or more, we're going to recommend a blood thinner for you. And so that is an important part of it, because even if your AFib is treated, that stroke risk can remain. And part of it is because we don't have a cure for AFib. Even if you've had an ablation, AFib can come back. And there are other factors, other vascular factors, other reasons you may be at risk for a stroke as well, just with the history of AFib. So that's something very important to recognize. There are other things that we consider when we kind of, in our heads, calculate someone's stroke risk. If someone has a condition called hypertrophic cardiomyopathy, if they've had more AFib than not, more persistent or chronic AFib, if they have kidney disease, if they have a very large left atrium where there's more scarring and more stasis of the blood flow, those are all factors we kind of keep in mind when we're calculating stroke risk. But really, it's that CHA2DS2-VASc score that determines whether or not we recommend a blood thinner or not. Now, many of you, how many, just for a raise of hands, how many people here in this audience are on a blood thinner? And when I mean blood thinner in this particular case, I'm talking about warfarin or Eliquis or Xarelto. Wow. Yeah, take a look around. That's thank you for sharing that. That's quite remarkable, right? And so a lot of people ask us, are the newer blood thinners, and we'll talk a little bit about the difference between aspirin and Plavix, but we're talking, when I mentioned warfarin, Eliquis, Xarelto, Pradaxa, edoxaban, people ask us all the time, are the newer blood thinners like Eliquis and Xarelto better than warfarin? And the answer is yes. There's been many studies, and each of those blood thinners have been compared directly with warfarin. And we know that those newer blood thinners are better at reducing the stroke risk. They're a little safer than warfarin in terms of spontaneous bleeding, and less likely to cause spontaneous intracranial bleeding. There was only actually one type of bleeding that may be a little better if you're on warfarin than those blood thinners, and that's bleeding from your digestive tract. But overall, the performance of the newer blood thinners, like Eliquis and Xarelto, is better than warfarin. And so this is a complex chart, but I just want to kind of call your attention. These are what we call guidelines, practice guidelines that are published from community consensus as well as research and evidence, and it kind of helps us guide us in our practice. And these are from the American College of Cardiology, Heart Rhythm Society, American Heart Association. But if you meet the threshold, we talked about the threshold on the CHA2DS2-VASc score for needing a blood thinner, that's greater than 2% per year, we're typically recommending a blood thinner. And our typical recommendation is usually the newer blood thinners, like Eliquis, Xarelto, unless you have a history of a mechanical heart valve or rheumatic mitral stenosis. And for those reasons, typically warfarin is preferred in those particular individuals. And people ask us all the time, is aspirin or Plavix an alternative to warfarin or Eliquis? And the answer is no. Aspirin and Plavix don't work in the same way. They don't work on the coagulation system in the same way. They work more on platelets. So they may be good if you have a stent or if you have vascular disease, but not if you have atrial fibrillation. And in the past, 10 years ago, 15 years ago, people even if they had a low risk score, CHA2DS2-VASc of 1 or 0, people are like, oh, you can take an aspirin, you'd probably be okay. We really do not recommend aspirin at all for atrial fibrillation. It's not the same. Doing nothing is probably better than taking aspirin, because aspirin can increase your risk of bleeding. But it is these other blood thinners that we use for atrial fibrillation, and that is the gold standard for reducing one's risk of stroke, particularly if they have a high CHA2DS2-VASc score. So what happens if you can't be on a blood thinner? If you can't be on a blood thinner, you've had severe bleeding, because the main side effect of a blood thinner is bleeding, right? So if you're at risk for bleeding, if you have a high bleeding risk because of other medical condition, we kind of calculate that with another score called the HAS-BLOOD score. If you've had gastrointestinal bleeding, which tends to be very common, that we see that with these blood thinners, intracranial bleeding, spontaneous bleeding, if you're prone to falls, what can people do? Well, the star of the show. We go back to the left atrial appendage. Remember that most of the clots come from that left atrial appendage. So surgeons have been thinking about that even longer than we have. When they've done open heart surgery in the past, they actually used to ligate using a suture that left atrial appendage. They would just kind of tie it off. We found that that's actually not that effective. Many of those times that they tie it off leaves a significant opening to that broom closet. So clots can still form and exit. And so AtriCure here. Surgeons now commonly use a device called an AtriClip that clips that appendage that can be effective when they do surgery. And that is now commonly used when people have valve surgery or open heart surgery or bypass surgery. People get this clip in, and that helps reduce the risk of stroke. Oftentimes, though, many people are still on a blood thinner after that. If surgeons can do it on the outside, can cardiologists do it on the inside? So I just want to play this video if I can. And it's from a movie you probably know, if I can play it. Let's see. But it's a if I can't play it, it's no problem. So in this movie, they come to Ed Harris's character, Gene Kranz, who plays by Ed Harris in the movie, and they say that the oxygen is going down, the carbon dioxide is going up. We got to fix this problem, otherwise our astronauts are going to die. And then Ed Harris or Gene Kranz he calmly tells them, well, you better invent a way to put a square peg in a round hole pretty rapidly. And they do that. The engineers do that. And engineers have been doing this, trying to figure out ways that we can go inside the heart, the same way that we get into the heart for an ablation through the vein in the leg, up into the heart and across to the left atrium. Can we go in there and plug that appendage with a device that could help protect you from having a stroke? And this has now turned into a reality. And there's a number of devices that are in production, in development. The most commonly used devices are the Watchman device and the Amplatz or Amulet device. And at our institution, we implant the Watchman device as an alternative for individuals who can't be on a blood thinner and they have a high CHA2DS2-VASc score. So this is an example of a picture of coming into the heart. We're coming in from the vein. The patient is asleep just like they're having an ablation, but this time instead of doing the ablation, we're coming in through the vein, up into the heart, into the right atrium. We cross over with a puncture into the left atrium with our catheter, and we're delivering the device that looks like a parachute into this appendage. And the hope is that it's a good round peg in a square hole, that we don't have any leak. That's what we're shooting for, that we don't want any leak around the device, and we want the device to be seated well and covering that up. And if we can achieve that, this is an example of what the appendage looks like with ultrasound before. During implant, you can see on X-ray kind of faintly the device there. And then afterwards, you can see with ultrasound the device in the appendage. And here's a CT scan with the device in that appendage of a patient who's had the procedure. But the hope is that that device seals it off and prevents that clot from traveling from that appendage up into the brain. It's not a end-all be-all because it's a process, and it doesn't, like I said, it doesn't eliminate all sources of blood clots. And for people to have a Watchman device or an Amulet device or some form of endopercutaneous closure, they still have to be on a blood thinner. And there's a process to get to the point where they can come off the blood thinner because the device has to heal inside the appendage, the body forms tissue over it, and then it can do its job. But in that process, they have to tolerate at least 45 days of a blood thinner, and then typically aspirin long term. And so those are important considerations, and we have that discussion before anybody gets this type of procedure. And even after the introduction of this device, people can have a stroke. That's what some of our research is about, is understanding how to manage patients with these devices, because it's not implanted and forget it. We have to still understand how to manage your AFib at the time, even though you have this device. Can you get a cardioversion safely? What is the best way to keep you from having a clot form on the device? And are there any gaps around the device or blood clots that can form on the device over time? So those are things that require continued follow-up. But what it is an alternative for those individuals who cannot be on a blood thinner, but they still have a very high risk of stroke. And it is good. It has been in the studies shown to be what we call non-inferior. So there are certain areas where it excels. You know, it's better at preventing serious bleeding because you're no longer on a blood thinner like Eliquis or warfarin. And it does a reasonable job protecting you against stroke, but it's not completely foolproof. So kind of just going through this, you know, AFib is becoming a very common arrhythmia and growing. As you heard, millions of people, 10 million people, upwards of 20 million people, and by 2060, 65 plus, I mean, it's a tremendous amount of people around the world that are going to have AFib. The lifetime risk of AFib for an individual may be 1 in 3 above the age of 55. And AFib increases the risk of stroke 5 times. So if you're high risk of stroke, based on your CHADS-2 VAS score, that's when we consider a blood thinner. And we prefer the newer blood thinners to warfarin, if possible. And if you can't be on a blood thinner or you're at high risk of bleeding, then we consider this Watchman-type device or amulet, some kind of percutaneous closure of that appendage. And if you're having surgery, for example, valve surgery or bypass surgery, oftentimes that can be done with the AtriClip surgically. And going forward, and this is just going to be starting actually already this month, people who have an ablation for AFib, particularly using the newer technology that Dr. Olson spoke about called pulsed field ablation, they may actually be able to have their, and we're starting this already, AFib ablation and Watchman at the same time. So it's a combined procedure. So they don't need a second procedure down the road. And there's a study that we were involved with called the OPTION study that was assessing the response for patients to have concomitant procedure, 1 procedure instead of 2, where they get both types of procedures done. So you address the rhythm and you address the stroke risk at the same time. And this particular study is going to be presented at AHA this year. It's going to be you know, we're all looking forward to the results of that, and it might dictate how we go about doing these procedures in the future. So with that, I'll conclude there, and we'll kind of go on to the next phase of our program. But I want to give, again, thanks to Dr. Zacabe and Dr. Olson, and hopefully that kind of gives you a little broad overview about AFib and stroke also associated with AFib. So to kind of better illustrate this AFib and living with AFib and a kind of real-world experience, I wanted to invite one of our most favorite patients, Betty Brandt, up onto the stage, and we're going to have a conversation with her and share her story with you because it's quite remarkable. Thank you. So Betty and I go back more than a decade. So she's had atrial fibrillation for more than 10 years, and she's been through everything. If it's okay with you, Betty, I'll just share your heart history a little bit. So she's had atrial fibrillation. She's had multiple ablation procedures. She's had a pacemaker implanted. She's also had other types of heart conditions that have needed to be treated along the way. She had a transcatheter aortic valve replacement. She's had coronary stents implanted for severe coronary disease. And she's had open heart surgery and bypass surgery as well. And at the time of bypass surgery, they actually implanted an AtriClip device as well. So you've had many of the things that we've talked about today through the course of your journey. And so I just wanted to kind of introduce you and then kind of just maybe start by giving a brief overview of your journey and how you're doing today. And she's 85. She'll turn 85 in February. Right. And she just had her first great-grandchild.
Right. That was the best part. I started, is it on? I started with Dr. Gupta when he came from the Cleveland Clinic 2012. About 6 months after that, my primary said, I think you need help. So I came to him, and he started me on medication. Well, that didn't work too well. So I had my cardioversions. I have had somewhere around 15 cardioversions. And I knew exactly when I go into AFib. I just immediately, I'm one of these people that knows when it happens. So I go in and have a cardioversion. Well, after that, a couple times didn't work so well. So we had our first ablation, and that worked for a while. Then I had a second ablation. Then I had a third ablation. And after the third one, he said to me, I was supposed to have some other problems. He said, Betty, wait for your mammogram for a month or two. He said, because you'll be too sore. Well, I go in for my mammogram, and I had breast cancer. So I've gone through that, went back in, and had to have it in 2019 or 20, had to have an artificial heart valve put in, a TAVR valve. I was really good, I thought. And then last year, exactly 1 year ago today, I went in and for a stint. And Dr. Palouse said to me, I can't do that. You need triple bypass surgery, which I had on the 31st of October last year. And I had multiple complications, not from the surgery, but from when they tried to take the veins out of my legs. I developed a lot of infections, and I was in and out of the hospital until end of April. So I am now walking better, but I had lost all my mass fat, thank goodness, in my legs though. So I'm doing better. I'm doing really good. Thanks to Dr. Sengupta. If it wasn't for him, I don't know where I'd be right now.
Well, that's very kind, but it's your history with AFib is quite remarkable because you were saying that how symptomatic you were, and I kind of want to bring attention to this because she, and Dr. Zakeib alluded to it, so she had AFib, and then she had those variants we call atrial flutter that were kind of a nuisance, and you felt those rhythms as well.
Also.
And that required more than one ablation. But what was interesting was sometimes we get to the point where we don't want to put you through more ablations, so we do this procedure called a pacemaker and AV node ablation. And the hope is that in those patients, once we do the AV node ablation, they may not necessarily feel the AFib anymore because their heart rate's not going to go as fast. They're going to have the pacemaker regulate the heart rate. But Betty is one of those rare patients where we did the pacemaker and AV node ablation, and she could still tell when she was out of rhythm. It
Right.
did not help her with her symptoms. And we do find that every now and then. So then we actually had to go back, and it was a scenario where we had to get the atrial flutter arrhythmias for her to feel better. And there was that one ablation that we did after your AV node ablation that
Right.
we got it. And can you talk about a little bit about after that? And
After
you've been-
that, I have been AFib free. Even when I had my heart surgery, they had a little bit of flutter for the first day, I believe, but then I went right back and I'm just fine.
And it kind of shows how you have to kind of tailor the treatment to the individual, because those symptoms and how it affects someone's quality of life is not the same from person to person. And you have friends who have AFib where share notes, but at the same time there are unique aspects of your care and your treatment.
Right, and as I said, right now I feel very good. My heart is working good and everything else. So thank you, everybody, the doctors.
But talk a little bit about the going through an ablation, kind of a less invasive procedure compared to kind of an open heart surgery.
Well,
how does that kind of fit into
The
your history?
ablation, I went in the morning and we did the procedure. The first one lasted quite a few hours, but after that, they were about 3 hours long. And I would go home the next day and I was just fine. And I just continued on with my normal daily routine. I didn't have any after effects at all. So.
Can you tell us a little bit what you enjoy doing nowadays and with your family and your grandchildren?
Right now?
Yeah.
Well, first of all, I live in independent senior living. I just made soup for 65 people, 7 different types, and I did all the cooking myself. I got that 3 weeks ago. I am now, I have had my first great-grandchild. I just finished making her baptismal gown. I just made 180 jars of jams and jellies for my family for Christmas. I'm knitting hats for everybody for Christmas. So I'm busy. So I'm keeping busy because I figure if I just sit, I'm going to die. So I have to keep going. And I'll be 85 in February.
And she even knitted for me when we had our first child a couple of years ago.
Right.
And I'm very grateful to her for that too.
That's it?
Anything you want to share?
Well, I don't know how much more I could share, but 3.5 years ago, I lost my husband, and that has been horrible. I mean, anybody, that's why I keep so busy, because I'm alone. I don't like to do things alone, so I do knit. I go to many different classes. I learn as much as I can. Every couple months, I take a different class doing something. I do exercises twice a week. So I just keep busy, and I thank the doctors who have kept me alive. So
Thank you, Betty, for sharing your story. It's really amazing, remarkable. Thank you. Thank you. Thank you. Thank you so much. So for this part, we'll do a moderated question and answer. Is that right, Maya?
We've got microphones, and
So I'd like to invite Dr. Zakeib and Dr. Olson, and also Dr. Hauser up onto the stage. You may know Dr. Hauser. He's one of our mentors, our long-standing retired cardiologist from the Minneapolis Heart Institute. He was also former CEO of CPI, which became Guidant, which is now Boston Scientific. So he knows everything there is to know about pacemakers and defibrillators and the history of medical industry and care in Minnesota. So it's great. It's an honor to have him here on the stage as well. But I'd like to open the floor up to questions, and then they can be for any of us, and we'll try to kind of field any questions from the audience.
I'd just like to go into semantics just a little bit. Dr. Zakeib, way back when you started your presentation, you referred to atrial fibrillation as a problem. And I understand then once you went on to how many patients per electrophysiologist, 124,000 patients per, that is quite a problem. But I have atrial fibrillation. I've been living with it for 14 years. And I don't consider it a problem. It's a diagnosis. It's an issue that I have to deal with. And listening to Betty talk, I don't think Betty's got a problem. She's worked through her issues. So I'm just curious how it is you came to refer to it as a problem. Obesity is a problem. We can do something about obesity. But atrial fibrillation, I believe Dr. Sengupta mentioned there's no cure for it. So how is it you come to use the word problem instead of diagnosis or issue or condition?
Thank you for that question. I would say I agree with you. I don't think Betty has a problem. I'm really pleased that she has been free from her atrial fibrillation. And it's a little bit ironic because after all those ablations, she finally is free of the arrhythmia. I'm not sure if you know this, that your 16th cardioversion is actually free. So if it ever comes back, I take your point about calling things problems. That I'm not trying to hamstring or label this issue as or denigrate people who have this problem or this issue, but it is a problem from the standpoint of trying to address the issues that come with atrial fibrillation that people who don't have atrial fibrillation do not have to address. And so when I try to address that concern, there are issues that we have to manage, that patients who don't have atrial fibrillation don't have to manage, and those are the risks that come with atrial fibrillation. So if a person brings me a concern like that or an issue or a problem, I'm going to try to manage it and I'm going to try to solve those problems. And so I would just say we can call it an issue or a concern, but to me, there are risks that come with atrial fibrillation, like the risk for stroke that Dr. Sengupta enumerated, and like the risk for congestive heart failure, in that in people whose atrium is running 600 beats per minute in a continuous way and driving the ventricle extremely rapidly in some patients, especially those who are asymptomatic, who don't have symptoms, it doesn't mean they don't have risk. And when they have rapid response to that atrial signal over time, it's like when you run the well pump with the well empty. You're underfilling the ventricle, and when you run it fast and underfilled, just like the well pump, with no water in the well, it's going to burn itself out. And so patients can develop a dilated heart with reduced heart function. So instead of squeezing briskly, like Michael Phelps, their heart just barely squeezes, and it's running really fast. So I won't take issue with the semantics of problem, but I'll just tell you, it is an emerging crisis. It's a public health crisis, and with each individual, we have to manage the symptoms of their atrial fibrillation, which is the palpitations and the fatigue and the loss of stamina and all the things that come with the atrial fibrillation. We also have to manage the risk separately. And so to me, it's a problem that I have to take very seriously, and I label it that way because it is front and center. When you're looking at a patient across the room from you, you have to determine how are we going to make them feel better and how are we going to make them live more safely in terms of the management of their risk for stroke and risk for congestive heart failure. But I take your point, and I appreciate that point. I don't want to denigrate that.
Wanted to make one comment on that also. Recently, in the last few years, data has come out to illustrate that maintaining normal sinus rhythm, even in the absence of symptoms, is associated with decreased heart failure and hospitalization. So it's a population approach and an individual approach. No one individual fits into the population. Everyone is treated differently, but as physicians, we have to make sure we're treating our patients collectively in a way that overall decreases heart failure, hospitalization, and complications. So that's the balance we all take care of every day. And that's one of the reasons why we really do try to keep everyone out of atrial fibrillation, is the data that has illustrated that quite nicely recently too.
I went for cataract surgery a couple of months ago. The little nurse there said, I think you have something going on, like maybe atrial fib. What? I said. So 2 months ago, I was told. I was just blown away. And because I've always been very healthy, no hospital stays, whatever. Since then, yes, I've been asking, okay, what do I do? What devices can I use? I mean, do I have to drag out my old blood pressure machine every day? Are there other sort of apps? And I guess what I am finding is the lack of education for the patient on all this high-tech stuff. This is fabulous. But for the individual, what can we use daily? I mean, do we have to get little charts out and all that sort of thing? And that's what so I can manage and do whatever I need to do. I said, is there a group of people that get together and talk about their atrial fib? Nobody seemed to know. And so for me, I don't know if other people have found that. The medical part is there, but there's a big gap from there to the patient.
That's a fantastic question. You know, I do think that there's a lot we can do that we're not doing to create that social and support and other things that we can do to support as a community our patients with AFib. I do think, and let me ask you this, is your AFib all the time, or do you go in and out of AFib as far as you know, how it affects you?
I think it's all, see, that's the thing. I don't quite
Yeah. Well, and I think that the really a conversation with one of us in clinic is what you need. You know, that's that, because I that is part of the conversation that we have with our patients, is that not only what are the strategies, as have been pointed out, to treat this, but how to manage it on a day-to-day matter at home. And nowadays we have tools at our disposal. Yeah, Dr. Hauser's going to, yeah. That's right. That's exactly right. Still, absolutely. So, so the amazing thing is that there are tools now that we are very happy that are out there that we can help you try to use to manage it on a daily basis. You know, we kind of say, you know, check your blood pressure at home, but there are amazing tools now that you can use to check your heart rhythm at home. And, you know, the Apple, you may have heard of the Apple Watch. You may have heard of the Cardia device. Yes, these are widely available now. And just like you would check your blood pressure, you could check your heart rhythm and heart rate at home with one of these tools. And there are new ones coming out every day. And sometimes they are a little bit more technical and require some tech savvy, but these are things that we can help with, or family members or other people we can identify that can help you to do that. And these are tools that really help us, because the questions of how AFib affects you guides us in terms of how we create a plan to treat your AFib. Does it? Yeah. Well, and that's where, you know, our website, there's resources from the American College of Cardiology, CardioSource. There are videos out there that would be good sources of information as well. But I think a clinic visit will be a good starting point.
There you go.
I have a question about people that have sleep apnea and use a CPAP. I've seen ads recently for people that do have sleep apnea and use a CPAP. They're recommending some sort of a device. They appear to kind of put it against their heart. I don't know if it's like an implant or something, put it against their chest, and that evidently it addresses the sleep apnea for that evening. Can you tell me how that relates to AFib? Is that a danger with AFib, or can you use this device, and do you know what it is if you have AFib? Thank you.
Apparently, I'm the technology guy, so I will address it. So there are multiple devices out there which use electrical energy to stimulate the nerve, typically in the back of the throat, or sometimes in the chest wall, to decrease obstruction. All right, and they're on the same lines as a pacemaker. They're implanted in different locations. Some actually require head and neck surgery. Some are done through the veins in the chest wall. Nonetheless, treatment of sleep apnea is one of the cornerstones of AFib therapy. So it's one of the biggest triggers. If you have sleep apnea, most all new AFib patients get treated or evaluated for sleep apnea. If you have sleep apnea, you need to treat it. Other things are, you know, weight loss, alcohol modification or cessation or limitation, and controlling your blood pressure, controlling your diabetes. I like this. The 5 things I'm going to tell you to help with your AFib are going to be the 5 things every other doctor is going to tell you if you ask them for 5 healthy habits. And sometimes patients don't like that. You want the silver bullet. If you eat this diet, take this medicine, and take this herb, everything's going to get better. But in reality, treating sleep apnea is a huge component of managing your AFib, controlling your blood pressure, controlling your diabetes, and weight loss are the key components to help decrease the stress on your left atrium. So yes, sleep apnea management is absolutely essential. Regarding the device implant specifically, that's a different topic. I think you have to look at how your sleep apnea is managed. What we care about in the EP world is that you're managing your sleep apnea well. That's a really important part.
Yes, I had a question about the number of people that have sleep apnea, but have AFib. Since my wife's been diagnosed, it seems like a lot of our friends have AFib as well. And you had mentioned that we went from 2 million in 2010 to like 10 million now. And I just wonder what the reasons were for that. And also if you could talk a little bit about what is the actual cause of AFib.
Talk about that one? No. So it's a great question, and it's a public health question, and it's also a question, a sort of a cultural question. I think there's a lot of influences there. The primary driver of this massive increase in the incidence of atrial fibrillation in the society, at least in this country, is the transition of our population as the baby boomers keep going down the road. I think I would say one of the most important predictors of atrial fibrillation, at least in my office, we call it high mileage. And I think as the population ages, more people come into the age group where there's been enough initiators of atrial fibrillation from or influences like high blood pressure, diabetes, valvular heart disease, thyroid problems. I mean, alcohol ingestion over a lifetime, prior heart attack, a variety of things that as they sort of are additive. And as the population ages, you have more people with more of those things and that develop atrial fibrillation. So we just have a glut of people with risk who are entering the age group where it finally catches up, and now we have a big group of people developing atrial fibrillation.
And the tools to diagnose AFib have improved. We touched upon the technology earlier, right? AFib can often be asymptomatic, but for people with wearable devices and other ways to check their rhythm, those are now, we do have patients come to us because their Apple Watch reported that they have AFib, and it's quite, it can be quite accurate too. So that's really a good thing, and that we're detecting it, because these complications of AFib can happen whether you know you have AFib or not. And so it's very important to identify it and identify it early and come up with a plan to treat it.
Thank you very much. I know there are more questions, but unfortunately we're out of time.
Can I add one thing? So I do want to bring attention to one thing that I wanted to emphasize. So technology in Minnesota is amazing. The Watchman device, actually the inventor of the Watchman device is sitting right next to me, Dr. Hauser. And Dr. Van Tassel and Dr. Hauser came up with the idea long before it's now Boston Scientific and Watchman. I just wanted to have him share a few words of that, because that is quite a remarkable story.
Well, when you think of inventing something, you usually see a person in the laboratory sweating bullets late at night, or in the animal laboratory during experiments, or reading and theorizing and doing what Albert Einstein did, and John Dalton and many other scientists and philosophers. So my story is a little bit different. And first of all, I want to say that I am not an electrophysiologist. I am a normal cardiologist who has been interested in medical devices my entire career. I was at a medical meeting in Mexico about 20 years ago, And I listened to a case presentation by a surgeon who operated on a woman who could not take her Coumadin, her warfarin, her blood thinner, because every time she took it, she bled from her bowel. And he decided that one way to treat her would be to go into her chest and remove her left atrial appendage surgically. It turned out that the operation was complicated. Her postoperative recovery was complicated. She had a collapsed lung. She had blood in her lung cavity. She had a chest tube in for a week. But eventually she recovered, and it did solve her problem. So that was the last case of the day, and I wandered out to the pool area down by the beach, and I sat down in the pool bar and ordered a margarita. And as I was drinking my margarita, I said, you know, there's got to be an easier way to deal with that left atrial appendage. And I drew a picture on a napkin of what eventually became the Watchman. So it was probably the margarita. I wasn't up here. I went back to Minneapolis, and I walked into Dr. Van Tassel's office. He was the boss. And I drew a picture of the proposed device on his blackboard. And he looked at it and said, well, you know, that's interesting. And that's all he said. About a month later, he came back to me and he said, Bob, do you have that napkin? And I said, why? And he said, we need to file a patent. And in fact, we did file a patent, and Bob Van Tassel and my name is on the original patent. But then the device became part of a company, and that company was called Atritech. And the three people who were really responsible for bringing the Watchman to clinical application, it's Dr. Van Tassel, Dr. Rob Schwartz, and Dr. David Holmes. They worked very hard on it. I was one of the original conceptual people, but I did not put in the time and effort that they did, because it took 14 years to develop the device, test it in animals, and then get FDA approval. That's my story.
That's amazing. Thank you. Thank you for sharing that. Amazing. And all at Minneapolis Heart Institute. So that's fantastic. Thanks, Maya. Thank you.
Yeah, thank you. I'll just say we have recorded today's event, and so we'll send out a link to the recording in the next week or two. So feel free to share with friends and family and review all the great information. So thank you, and we'll collect your name tags on the way out. So.